Welcome friends, welcome viewers, welcome on MuniMeterHealth, your source of learning cardiology and human heart. This is Dr. Jaitly from New York, your cardiologist. Welcome my dear students, residents and fellows on MuniMeterHealth. Without any further ado, I'd like to say this is purely a channel which is promoting medical education and patient education in order to improve the patient health literacy so that we can have a better clinical outcomes in our cardiology community. Having said that, if somebody is having an emergency, please call 911, get to the nearest hospital, consult a doctor right away, because this is purely an education channel. We are not offering any recommendations and no prescriptions either here. So being a purely an educational channel, let's delve into the subject matter right away. What is SCAD? Which is spontaneous coronary artery dissection. It's also called spontaneous coronary artery dissection. In short form, the acronym is SCAD. What is SCAD? This is a condition which results from a non-traumatic, non-iatrogenic coronary arterial wall dissection. Remember, the arterial wall has three layers. We know the adventitia, then we have the media, and then we have the intima. So any of these three layers between this arterial wall can be involved, and a false lumen is thereby created. I'm showing it in a different color here. And as a result, now what happens when you have a false lumen? This is a cross section, this is a longitudinal section, as you know. So a false lumen is created, and as a result, this can start slowly encroaching upon the actual lumen of the artery, and as a result an obstruction can develop. Likewise, it may happen here in this fashion, and as a result the arterial flow will be compromised, and that results into a coronary stenosis or coronary obstruction, and as a result these patients present with myocardial ischemia or angina. Now the history and physical are very important. The history will clearly define that these patients, they will have an acute coronary syndrome as a presentation. So automatically these patients belong to the ICU and CCU settings, where EKGs, cardiac enzymes, and subsequent evaluations for ACS are being done. Sometimes these patients can be asymptomatic. It can go undetected. If it's a minor, very small amount of luminal obstruction or a dissection that has occurred spontaneously, it can go undetected. Many times these patients present only in a sudden cardiac death episode, especially if there's a full obstruction of a major artery like a left anterior descending or a left main. Now, for the student's sake, just remember that SCAD normally affects only one vessel. It does not affect multi-vessel, although multi-vessels have been reported. It's not that it's not found, but it's not uncommon, but it's normally affecting either the LAD, this being the left circumflex, and this being the RCA. So for the student's case, sake, I will do this. This is LAD, and this is the left circ, and this is being the right coronary artery. So having ascertained that, these obstructions can. Now, obviously you have to get an EKG right away, and an EKG will suggest an ST elevation, which will be present in the precordial leads V1 to V6, and obviously a suggestion of an acute MI is made based on an EKG and the acute coronary syndrome presentation. These patients therefore will be admitted to the ICU. So you admit the patients to the ICU. At that point, you run the whole gamut of EKGs and the cardiac enzymes and troponins and CPKs, etc., and then ascertain whether these patients are now developing further acute coronary syndromes or are they actually infarcting. EKGs will have to be run every 3 to 4 hours in order to ascertain what's going on. These patients then are referred for coronary angiography. They get a coronary angiography within the next few minutes to a few hours, if you will, after their presentation, having ascertained that the ST elevation is present. At that point, three types of coronary lesions have been identified. One, they are very diffuse. I'll show the diffuse in a different color here like that. So this is the commonest presentation, which is sometimes very hard to diagnose, and this is seen in mostly about 70 to 75% of the cases. So this is one type. The second type is where you have the dye when you inject the dye, it'll just get hung or there might be a partial hung, we call it a hung up here. So the dye just stays there as a result of this false lumen that has been created in these schematics like I've shown. So these patients can actually have a hung up of the dye. So that is present in roughly about in 20% of the cases. So here's a hung up dye, which is type 2. This is type 1, where diffuse lesions are present, and then you have the type 3, which is a rarer variety in the 5% of the cases, which is very, very difficult to diagnose. Why? Because they mimic almost like there's an atherosclerosis, like a stenosis present, or a very discrete form of focal stenosis present in these various arteries, and one cannot really say whether it's actually coronary artery disease from atherosclerosis or is it the SCAD that has occurred. Now, in which patients are really prominently affected? So remember that it's commonly present in the females. So the ratio roughly between females to male is 9:1. So this is a remarkable thing that's prominently present. Now it's invariably associated with pregnancy. It normally occurs during the time of the labor or the labor or delivery at the time. And it may, in other words, implying hormonal changes that are occurring in the woman, or at the time of the physical stress, unusual physical stress that the patient is undergoing. It can follow a very high strenuous activity, like somebody performed strenuously in a gym or ran a marathon, etc. So these patients can collapse as a result, and these patients can present with SCAD. Again, in men specifically, it is related to physical stress or emotional stress, whereas in women, it is commonly associated with pregnancy. Hormonal changes that occur during the time of pregnancies are very important. Of course, hormonal therapy can also impact on that. Valsalva, because that is commonly seen in many of these situations where the woman is exerting with the diaphragm being actually required to push the uterus during the time of the labor delivery. So you have the Valsalva maneuver happening, and as a result, these patients can also dissect their coronaries, and they may sometimes have dissections in renal or mesenteric arteries also. Remember that. So the same dissection process can occur in other arteries as well. It's not unfounded. Now, fibromuscular dysplasia must be excluded, and any other form of arterial dysplasia should be excluded. These are the other causes of SCAD, if you will, like connective tissue disorders, specifically Ehlers-Danlos, Marfan's, systemic lupus erythematosus, and all these conditions must be excluded at that time. Fibromuscular dysplasia should be also excluded. This could be a genetic form. Again, the genetic studies are normally reserved for research and family history, if that is prevalent. So all those things will really matter. So ACS is the usual way the patients present with, sometimes with sudden cardiac deaths, and of course many times they are asymptomatic as well. But ACS is the commonest way these patients of SCAD will present. Now, having done the coronary angiography, again, these patients, once you have ascertained that there is a dissection occurring, a conservative plan is there's the management. In other words, you start with low dose aspirin. You cannot anticoagulate these patients because that can further compromise on these false lumens and the bleed. Remember, the bleed is occurring within the arterial wall, within the arterial layers, and that's what is creating this false lumen. So you have to be very, very careful in making a decision whether or not this is you're dealing with a SCAD or you're dealing with atherosclerotic thrombus. So therefore, it is very, very important for us to really ascertain that. Clopidogrel should be continued at least for a year. Low-dose aspirin on a long-term basis throughout the life is highly indicated. Aspirin is indicated in these patients. Again, please exclude the history of allergies whenever you're discussing aspirin and clopidogrel. Now, there are certain places where aggressive management is offered. When would you do an aggressive management? And that is like offering either a cabbage or you're offering a PCI. So a cabbage is indicated when you have a left main which is the culprit lesion or the proximal LAD. If that is a proximal lesion where there is a false lumen or a SCAD happening either in the left main or LAD, remember that that is a big chunk of left ventricle that is being affected, and as a result, one can really, compromise the survival in these patients. So CABG is very highly indicated. A PCI, specifically if it's a proximal LAD, say somewhere here, right? If there was a SCAD happening, you could conceivably offer a PCI or an angioplasty there and try and put a stent and make sure these patients actually benefit from further progression of there. Now, many times these patients, if they're recurrently having SCADs, then also patients and aggressive therapy is offered to those patients as well. So remember, there are certain criteria. It's not like all patients across the board will require conservative therapy with aspirin and clopidogrel. There are aggressive modalities of therapy that can be employed in the setting of SCAD, specifically so if the left main is involved or the LAD is involved at the proximal junction. So having said that, I've already defined how the clinical presentations are. Diagnostic tests, as I said, CTA and MRA is recommended only in a setting where after these patients have been stabilized and or they have had the therapy performed, then one can exclude fibromuscular dysplasia, you can exclude morphons, etc., and other causes of arterial dysplasia by modalities called CTA, coronary tomography, and angiography, and this is of course magnetic resonance angiography, MRA. So having understood this as an entity which is now increasingly being recognized, it was always underdiagnosed. Remember, almost 25% of the young females, let's take that off, 25 to 30% of the young females, specifically less than age of 35, who are having an acute MI presentation, should be excluded for SCAD. And the chances are you would be dealing a great deal of SCAD in those young females, because women are protected. We know women are protected because of their hormones or the ovaries and estrogen. They're protected from any atherosclerosis. So if these patients are presenting with acute coronary syndrome or with an acute myocardial infarction picture on an EKG, they should be excluded for SCAD by coronary angiography, and therefore it is very, very important to do that. So it's an increasingly, we are trying to make the awareness possible, and that's our goal through our video presentations here. We want to make sure that we improve the patient education as well as the medical education in order to improve the health literacy, and therefore the clinical outcomes will be better. Once again, this is an education channel. Please consider watching us continuously. Share these videos with your friends, your colleagues, and of course your rest of your fellow students and residents, and continue to watching us on MuniMeterHealth. I'll be back again with another interesting topic in my next video. Thank you again. This is Dr. Jaitly. So long.